Hey, happy Monday afternoon. Dr. Alan Christensen here with you, and welcome to Office Hours Live. I'm with you guys right now on Instagram, on Facebook, and on YouTube. And I want to talk a bit today about nutrient testing. So I had a few talking points queued up about that. So as you're coming on, this is Office Hours Live. Welcome, welcome. I'm seeing a lot of folks come on right now. Happy to hear from you, and let me know where you're from. I'll grab a couple of key questions today as well. So the main theme will be about nutrient testing. I'll talk about some of the most important tests you want to get done, some of the tests that are most misleading, why that might be, and some big ins and outs on nutrient testing. So welcome. Yeah, lots of folks coming on right now. Good to be with you guys. And I'll be keeping an eye out for comments and questions as well. So on Instagram, you'll see and hear me. If you're on the YouTube or Facebook, you'll see the images as well that I'll refer to, but it's all good anyway. We got Sean with us from Seattle. Thank you for holding office hours. These are wonderful educational opportunities. Thank you so much, Sean. I appreciate that. And we've got someone here from Instagram on Scottsdale saying hello. So yeah, welcome. It's good to see wherever everyone is from. Someone here from Hawaii. That's really cool. So we got a big range covered so far. I'm in Arizona still. And as of June, I'll be doing these out of Minnesota for the next little bit and back and forth somewhat, but up in Minnesota for the coming summer. So yeah. Now we got someone here from Florida, beach in California. So we got pretty good coverage going. We got some questions coming in already here about free T3 levels. Always a big one. We'll talk about that. We got Melissa here from Nebraska. Joanne's back with us. My friend Joanne, how you doing, Joanne? More from California. Yeah, sorry you guys about last week. We had a power outage. Most bizarre thing. First one we really had here, and it went on for a while. Someone else from Minnesota. Welcome, welcome. Near and dear to my heart. Philadelphia. Question about parsnips. Why aren't they on the metabolism reset diet? That's a simple one. They should be. If that was an oversight, that would have been my mistake. They're a really good food. They're examples of very healthy vegetables and kind of a unique category as well. I can come back on that. More coming in from Albuquerque, New Mexico. That's cool. We've got a family in Santa Fe, so we passed through Albuquerque, and that whole area is really neat. So yeah, nice to see folks from all over the country. So let me grab a couple things about nutrient tests here for you guys. So yeah, the images will show up on a couple of the platforms, not all of them, totally okay. So the first one I want to talk about for nutrients that often get confused and can be misleading for people. First one's vitamin D. And this is one, you hear about this all the time in the news. Anything you could shake a stick at, vitamin D seems to help with. Well, so what's happening is our perspective on vitamin D is changing a lot. It turns out that vitamin D is an acute phase reactant. What that means is when your body's inflamed, inflammation changes vitamin D levels. And that's why whenever somebody is sick, their vitamin D levels are low. We used to think that having low vitamin D made you sick. It can. Of course, it can be a bad thing to have it too low. But now we know that it looks to be a much bigger cause where it's probably more of an effect in many circumstances. So the current idea is that it is a negative inflammatory marker. So the more inflamed your body is, the lower vitamin D goes. And yeah, this is like a little teasing apart cause and effect. So let me know if it makes sense or if it doesn't. But think about like umbrellas and rain. If you see a lot of umbrellas out when it's raining, you could think, well, umbrellas make it rain. But we know that that's not true. So things can go together, yet the causal direction may be reversed. One A may not cause B, B might cause A. Or it could be that C causes both A and B. Or in this case, if inflammation is C, it causes B, which is whatever the bad health outcome is, and it makes A go low. So that's the biggest finding about that. And so testing it, we always have to realize that if ever someone is sick, that will skew their vitamin D levels. And that can be sick in a chronic ongoing way as well. So there was a paper that looked at vitamin D levels in people pre and post surgery. So really, no big differences in their long-term chronic health, but definitely differences in their acute inflammatory load. They just went through a surgical procedure. And what they showed is that in a matter of just a day or so, vitamin D levels plummet for someone who goes through surgery. And the relevance of that is just that it's proving this point that a really big rise in inflammation makes a real big plummet in vitamin D. So a lot of folks jumping on. Hello to another one, Anthony here coming with us. Yeah, let me know where you're from. We're seeing people from all over the country. I haven't seen too many other countries just yet, but we often do get that. And I'm taking a minute to talk about nutrient testing. We know that that vitamins are critical for our health and that people are different. It's not the one size fits all. So you want to know what your needs are and if there's something you're personally low in. And it makes so much sense to test for nutrients and treat them accordingly. But some tests aren't done, and some tests are quite misleading. And I'm talking about a couple of the biggest ones today, the most important ones to do, and ways in which they can be confusing for people and send someone the wrong way. So vitamin D is a big one here, both for importance and also room for error. Oh, now we got some from Sweden. Now we're getting international. Welcome. So vitamin D, we just showed that its levels can change radically because of inflammation. So we thought in the past that low vitamin D caused many illnesses. A caused B. Then it became less clear. And now what's gotten clear is that inflammation, let's call that C, causes illnesses and it causes low vitamin D. So it's not so much that low vitamin D causes all illnesses. It certainly does contribute to some, but a larger factor is that inflammation makes vitamin D get lower. And the study I just mentioned showed how vitamin D changes radically in a day or two when someone has surgery. And if you think about the ongoing things that affect vitamin D, your sun exposure, your vitamin D intake, factors like this, body composition, those don't change in 48 hours. But vitamin D levels plummet when inflammation goes up within 48 hours. And this is just one more proof of the new understanding that inflammation causes illness. We've known that, but inflammation also causes low vitamin D. And that's why almost any illness you shake a stick at, if you look at people who are sick and compare them to those who are not, they probably have lower levels of vitamin D. And we thought for a while that low vitamin D made them sick. Now we know that being sick gave them low vitamin D. That's probably a more relevant factor. Now, there's one other point about vitamin D that throws people off quite a bit, and that's the way in which its benefits are the greatest at a narrow range. So when you're above a certain threshold, vitamin D is less helpful than when it's lower. There's an image I'm sharing here on Facebook and YouTube Live, and it's showing how vitamin D relates to mortality. We see that it connects to a lot of health conditions, but it also ties to total mortality risk. And, whatever else you can say about any other symptom or disease, you can't really get much more significant than being alive. It's like, if you're not there, nothing else really matters. So we see that when someone is far too low, they've got higher mortality. But when someone starts getting on the higher side, mortality creeps up again as well. So this is one of these inverse C-shaped curves, they're called. And the sweet spot is somewhere in this 30 to high 40 range. Now, a big thing about vitamin D is that there's two different units in circulation. There's nanograms per mil and nanomoles per liter. They're basically like inches and centimeters, or inches and feet, same sort of a thing here. They're standard in metric units. And a lot of the studies suggesting that vitamin D was helpful when it was up on the high side, up in the 70s or 100s or above. That's true for metrics, for nanomoles per liter. But we have standard units on our blood test. We have the nanograms per mil. So when we translate that back in, you don't need to be all that high. You don't want to be deficient. That's not good. But higher is not better. And above, really not that far up from the lower part of the normal range, the benefits start to diminish quite a bit. So I'll grab a related question or two about these, and then we'll grab some more general questions too. So more folks are coming in. New York. Here's one from Ecuador. That's cool. Phoenix. Okay. So vitamin D, just some questions about that are popping up. Good levels. Test in this. Is it a must to test vitamin D in the summer months? So good question. So vitamin D, yes, of course, it relates to sun exposure. And the funny thing there is that's more relevant how close you are to the equator. The further you get from the equator, the less of a connection there is. And then also how much of your body's exposed and what time of day you're exposed. So if you're in an equatorial area, you're in your Speedo, you're outside at noon, and also your pigmentation. So the more pigment you have on your skin, the more you resist vitamin D. And this is kind of fascinating. Vitamin D, in excess from sun exposure, it depletes folate. So when you make too much vitamin D from the sun, you end up making a relative folate deficiency. So if you have a lot of sun exposure, you need to modulate, you need to control the vitamin D and not make too much of it. So that's why skin becomes darker. And on the other hand, if you're quite a ways away from the sun, you need to let the vitamin D in because you don't get that much exposure. Your skin doesn't really get that much directly on it. So the time of year you test it doesn't tend to vary too greatly for most people. And this is from Hilly B on Instagram. Yeah, it normally doesn't vary too much. Again, unless you're more fair complected, you're more equatorial area, you've got a lot of exposed skin, you're outside a lot midday. Those things cause it to change quite a bit more. But practicing here in the Sonoran Desert, where our sun is crazy intense, we see many people that are still markedly low throughout the year. So that's rarely that big of a factor. And then a couple of the related thoughts. I think I actually saw this one come up twice about the relevance of vitamin D and immune health / overall risk for infectious disease. I'll mention that. I want to address this one comment from Melissa with us on Facebook. If inflammation decreases vitamin D, should they increase vitamin D to bring the levels back up? That's also a really logical question, Melissa. And here's how the chain of thought process has gone. Now, the goal of bringing vitamin D back up would be to help health outcomes, right? To help stop a bad thing from happening. So, Melissa, let's take, for example, infectious disease risk. This has been studied quite a bit lately with vitamin D. So the thought is, yeah, if low vitamin D, if that's a bad thing. So what I'm arguing is that inflammation lowers vitamin D, but in a way that may not be harmful. I didn't clarify that part, so thank you for that. So if the lowering vitamin D was inherently harmful, then raising vitamin D should reverse that problem. So in the case of infectious disease risk, for example, if people with low vitamin D are more apt to develop infections, then the follow-up question is, would raising vitamin D lower their risk of infection? And this is where the disconnect has happened. There's so many things where we've seen, sick people have low vitamin D, but then when we give people vitamin D, they stay sick. It doesn't really change things. And this is the case for infectious disease as well. If you supplement with that above normal intake amounts, try to raise people's levels back up again, it doesn't radically change the risk. So that's why we think that vitamin D is not causing the problem. It's more so being caused by something else itself. So it's not that low vitamin D is caused by inflammation, and because of low vitamin D, then sickness sets in. That's not so much the sequence. If that were the case, then sure, you could say maybe just taking a massive amount of vitamin D would offset the sickness. But the emerging model is that inflammation causes low vitamin D and causes illness. There's some arguments that the low vitamin D might even be an adaptation. There's some things that happen in response to the body being sick that are adapted, some things that are not adaptive and counterproductive. So, for example, going into shock, some of the severe states of shock are just dangerous and they need to be blocked and reversed. But some things that happen in the body in response to acute illnesses are neither productive nor counterproductive. They're just responses that are not useful. And so far, it looks like low vitamin D is not an adaptive response, but also not a maladaptive response. So overall, it is smart to keep vitamin D levels in a good range. There's a graph that I'm showing that suggests that in the mid 30s to somewhere around the high 40s to low 50s, that's where we have the lowest risks of total mortality. Now, a follow-up question, the COVID literature suggests that vitamin D over 50 provides significant benefit. That seems higher than what your graph suggests is ideal. What are you recommending? Yeah, good question, Sean. So in terms of benefit, now I would pull this apart. There have been studies showing that people that are a little higher in vitamin D are less apt to catch illness like COVID and less apt to get complications. So that's one thing. That's what happens to people based on their vitamin D levels. Now, that doesn't mean that making someone's vitamin D levels higher changes their risk. So if someone's vitamin D is not on the higher part of the range, does a mega dose of vitamin D improve their risks? And that's where it does not. So, in terms of just good benefits from amounts that are achieved through supplementation, that's still that mid 30s to mid to low 50s. So, yeah, and that syncs up pretty well with infectious disease risk, long term mortality risk, lower risk of developing or worsening of thyroid disease, other general health outcomes. They all seem to fall somewhere in that range. For most adults, that looks like maybe 1,000 or a couple thousand IU of vitamin D per day. When I update the daily reset packs, I use the Thyroid Daily, the new Thyroid Daily multi, and I put 1,000 IU of vitamin D in that based upon these latest targets. And really, that's a good baseline amount. There are some that need a little bit more. There's few that need much less than that. Most need about that range. Thank you for that feedback, Sean. I just realized I've got a really detailed paper on vitamin D. I'm going to put this link up for you guys. This will show up on YouTube and Facebook. Let's see here, how much vitamin D is right for you. This talks in great detail about those factors that I mentioned about the skin pigmentation, the latitude at which you live, how much skin exposure you've got. Another thing is body composition. So one's body mass index, BMI, is not a perfect marker of health, but it is a predictor of vitamin D requirements. So those that have higher body mass indexes often need more vitamin D to achieve the same levels. And yeah, I talked through all of that in that link. On Instagram, if you just Google Alan Christensen vitamin D, it's the first thing that pops up. So that's about vitamin D. And I think I got the vitamin D questions. Let me just grab a few more comments on a few other nutrient tests that are often misleading. Then I'm going to jump on a few of these questions that came in live here. Okay, the other one I want to mention briefly, I won't spend a lot of time on this. I've done some deep dives in this. If there are questions that come up about it, I'm happy to address them. But this would be iron. And the big disconnect about it is that while it's not tested thoroughly, but even more so, the earlier versions of it being low are well within the normal range. They're kind of in the middle of the normal range, actually, for ferritin. So there's many ways you can test iron. And in most cases, it's best to test the full panel to get a full context of that. But when the full panel all syncs up and makes sense, then ferritin is the earliest indicator to show iron is starting to get low. We call that latent iron depletion, and that's the first step toward an iron deficiency. And there's various steps by which that can progress. Most labs call ferritin normal as low as 10 nanograms per mil, but there's good data showing that if one has thyroid disease, being below even 100 may start being problematic and it may start causing fatigue symptoms. So that's a big disconnect where people can be underdiagnosed and undertreated. Often not even tested, or if they are tested, often just told they're normal when they really could stand to benefit. And this is because all the ways that iron interplays with thyroid hormones, how they interact with one another. Okay, I'm going to do a pause before going on to calcium and just do a quick check-in. So good to see you guys. What are good levels? I just saw that. I'm assuming that was talking about vitamin D, and I think I did cover that one. I think that one was a answered question. Good range for 65 and older, so vitamin D still. Yeah, good question. This is one to where there's not a lot of big differences per age. And many things are quite different throughout the aging process. But as long as we're talking about adults, our vitamin D blood levels aren't that radically different as far as which ones are best throughout the health span. Great comment from Dawn about, is vitamin K2 with vitamin D3 essential? So yes, essential in that what vitamin D does is it helps bring calcium into the bloodstream. And it's not that you could not absorb or utilize or benefit from vitamin D without K2, but the drawback is that if you were K2 deficient, if you were lacking in these phytoquinones, these K-like compounds, then you bring in calcium, but you might send it to the wrong place. That's the worry about that. So calcium can mineralize bone, or it can calcify the tissues. It can calcify the blood vessels of the joints. We want calcium to do the good things and not the bad things. And if someone is vitamin D deficient and they're vitamin K deficient, well, they're not absorbing calcium well, but thankfully they're not misdirecting it either. So if they reverse just the vitamin D deficiency, now they can absorb calcium, but they still need vitamin K to properly distribute calcium. So it's not so much that, yeah, they work, all nutrients need each other in various ways. This is one example of that. So speaking of calcium, I'll touch on calcium here for a bit. So this is something to where it's really common in blood tests, but the blood levels, so two big problems with them. One of which is that they have nothing to do with your calcium intake. Nothing to do with. Well, not nothing, but you've got to be consuming like almost zero calcium or just tens, I don't know, 3 to 5,000 milligrams or more per day before your intake has any effect on your blood levels. So for almost everyone, your intake of calcium, good, bad, or sideways, has no bearing on your calcium blood levels. That's the one big disconnect I want to point out first. The second one is that a lot of people may have normal calcium levels, but they could still have problems with their calcium uptake. And the main issue here is parathyroid disease. So when there's hyperparathyroidism, there's too much calcium brought into the blood. And calcium is a big part of signals going from nerve to nerve and cell to cell. So when there's too much of it, all these signals are goofy. And we can see almost every symptom imaginable, really bad fatigue, anxiety, bowel cramping, joint pains, mood changes, you name it. And even the smallest changes in calcium can do that. So when calcium's blatantly above range, most labs call normal range up to about like 10.5, 10.6. When they're blatantly above range, in most cases that gets caught. Not always. If anyone's experienced this, let me know. But I've seen a lot of people to where I'll see them and their blood calcium levels are high. And I ask them about that. And they say, oh, my doctor said that was no big deal. It's a big deal. It's never not a big deal. It's always a big deal. The most common cause is hyperparathyroidism. The next most common causes are still big deals. It's always a big deal. But the big point is you could be normal and it still could not be right. And there's a graphic I'm showing on Facebook and on YouTube Live that expresses that. This is from the Norman Parathyroid Center. They are just world class for treating parathyroid disease. And it shows how in the normal range, but above 9.8, boom, right there, put a line right in the sand there. Above that line, it starts to be questionable. And if someone's calcium is recurrently above 9.8, there can be early parathyroid disease. So that's the big issue about calcium and how it's kind of goofy. I saw a couple of questions pop in about iron. I'm going to backtrack and look at a few of those because I was just talking about iron. Vivian's got a really good question. Better time in the menstrual cycle to test for ferritin levels and or hormone blood panels. So stored iron doesn't change too terribly much, Vivian. If one is lacking in iron, they can be a little lower right before or right during the menstrual cycle. Right before, because before the flow starts, the uterine lining is getting engorged and some blood is being redirected there. So there can be a bit of a change then if someone's on the lower side. Otherwise, not a big effect. Now, hormone panels, yes, and it depends a lot on what you're looking for. As a generalization, if you're wanting to measure estradiol and progesterone both, they're usually most accurate between days 17 to 23 of a 28-day cycle. Thyroid hormones are not as they are accurate during the latter part of that window, but not during the early part. So if you want to measure about like day 22, day 23, as precise as that is, you can then measure estradiol, progesterone, and thyroid hormones. There are times to where estradiol may be measured at the earlier portions of the cycle, as can thyroid hormones, but mid-cycle is not good for thyroid hormones. So yeah, good iron question. Another iron one is ferritin measuring free iron. What if our genetics testing says to ensure our free iron levels are not elevated? Yet I'm trying to get high levels for my Hashimoto's, fatigue, etc. So ferritin is measuring stored iron. It's measuring iron in storage. Free iron, there's serum iron. There's a lot of ways to measure iron. Your genetic testing says to ensure our free iron levels are not elevated. Krista, yeah, if you want to even give some more details about that, free iron levels, not a common nomenclature for lab tests. Ferritin itself, stored iron, can elevate in cases of chronic inflammation, kind of the opposite like vitamin D does. But yeah, otherwise not a concern that way. Okay, I've got So I've got a lot of really good questions, you guys. And I was going to talk briefly about what do I have? One more test? Yeah, one more nutrient test. I'll dispatch with this one really quickly, then jump in on a few of your questions. There's some really good ones. Well, here's one that's just still relevant about iron. Yeah, I'm gonna talk about these because I did bring these up, iron and calcium ones that just came in. So Claire, my calcium level is 10.5, still testing me all the time. Ultrasound showed nothing. What to do? Claire, so 10.5, that's almost always significant. The first thought, Claire, is hyperparathyroidism. That is not diagnosed via ultrasound. That will not consistently show ultrasound findings. So, Claire, the steps would involve testing parathyroid hormone output. And this gets a little bit in the weeds, you guys, so hang with me. I think that a lot of you will get this, and I want to share because of that. What should happen, Claire, if your parathyroid function is totally healthy and your calcium is on the highest side of normal, your parathyroid hormones should be on the lowest side of normal because they should be not trying to pull in any extra calcium. If that's the case, that means your parathyroid glands are off the hook, but you still want to know why it's consistent. It may be okay for you, it may be normal, but it's still worth watching and monitoring because that could change. Now, on the other hand, if your parathyroid hormones were normal, but mid-range or high normal, then that's not normal. So yeah, you could be in range, and you could be high normal in calcium and in range, and high normal in parathyroid hormones but in range. That's not right, because when they work right, your parathyroids should slow down to stop making you pull in calcium as hard as they were. I'm getting that image back up again for those who are seeing those. So yeah, what should happen is the parathyroid hormones should lower to compensate. If they don't, that means there's a problem. But that really would be clear, just digging deeper. And a resource to mention to you guys too. So you've got the option of talking to me one-on-one. I do second opinion consults. I can talk through things like this. I do have a few openings this season before summer kicks in. Those are at thyroidopinion.com, just thyroidopinion.com. You can book me. We can talk in great detail about your situation. We can talk through your labs, help make sense out of things, and I'm happy to make a good difference. I don't do prescribing in those, and I'm working with people wherever, whichever country, whichever state. Because I'm not acting as a prescriber, I'm not limited by just states in which I'm licensed to practice. So yeah, wherever you are, you're welcome to just grab me. We can get on Zoom live, just you and me one-on-one, and look through in real time all your information and give you some good answers about stuff. So that's always an option too. So one more one about a topic we brought up was I always come out low in iron, but my doctor does not want me to take iron because I am menopausal. Can you elaborate that on that, please? Well, I can elaborate on that, but just knowing those two things, I would disagree. There could be more factors that I'm not aware of, and I don't want to say your doctor's wrong because I just don't know all the possible details. But what can often happen, however, if I didn't know a woman's iron levels and I knew she was menopausal and not losing blood with menstrual cycles, I wouldn't say take iron without knowing your levels because, yeah, menstruating women often lose iron. Women who are not menstruating don't lose as much. And in many cases, they don't need to take iron. So, Marcella, if I didn't know your iron levels, yeah, I wouldn't say take it because you're menopausal. Now, on the other hand, if I knew your iron levels and you were low in that wouldn't matter that you were menopausal. So it may be a matter of wanting to explain why you're low in that. It may be something that still needs to be sorted out, but that doesn't change the treatment ideas. You want to really diagnose why you're low in that, but still treat it and still address it. So yeah, being menopausal takes away one of the more obvious causes of being low in iron, but it doesn't really change the benefits or the good things about treating it when it's deficient. Okay. I've got a lot of really good questions here that have popped up. I'm going to quickly just mention this about iodine. I always get questions about serum iodine. Why My doctor said I should take it because my blood test showed that I'm low in it. And here's an example of a blood test someone had not too long ago. And yeah, lots of folks are low in serum iodine. It has no relationship whatsoever with your body's need for iodine. It just doesn't. There is an image I'm sharing now, and this shows a large group of people, their serum levels of iodine and their urinary levels of iodine. Now, here's the thing: the urinary iodine is completely meaningful for a big group of people. So when you're checking a lot of folks, the urinary levels do correlate with the nutritional status for the group, not the individual, but the group. So what this shows is that there's just no connection between nutritional iodine and serum iodine. Now, there's a very good connection with toxicologic iodine and serum iodine. So when you ingest so much that it's damaging your kidneys and they can't regulate it anymore, that's when blood levels start to go up. But before then, low blood levels don't mean low body levels. It's just not relevant in any way. So yeah, I don't think I need to spend too much more time on that one. Let me clear off the images. There we go. Now I can grab a few more of these questions. And those who are just coming on, welcome you guys. I'm with you on Instagram, YouTube Live, and Facebook. I had a few discussion points about common nutrient tests. So important nutrients to test for, but also not to be misled for, because they can be really confusing and they might mean the exact opposite of what you think they mean, which is crazy making, but I don't make the rules around here. That's just how it is. So a couple more questions. Let's see. Here's a couple from Sean, one of which is, why would one have perpetually low free T3 when TSH and free T4 remain optimal? So Sean, the deeper question is that significant? Does that mean something bad? And there's a lot of people that talk about it's important to have T3 levels on the high side of the range. And here's the rationale behind that, Sean. So the truth is that TSH is an inverse marker. The higher the TSH is, the less your thyroid is making hormone, and vice versa. A low TSH means your thyroid is overproducing. And within the normal range, healthy people have lower TSH scores. They generally have scores on the low normal side. So a lot of doctors have seen that fact, which is a very solid fact, and they've said, oh, if healthy people have low TSH, then healthy people must have high free T3 and high free T4. Well, you could think that, but the problem is that the free T3 and free T4, they don't change as easily. Your body puts them where it wants them for a lot of reasons that are not just tied to the TSH. So if you overdose someone, if you give them a massive thyroid overdose, eventually their TSH goes low and eventually their T3 goes high. But before then, the T3 might go low because the body's getting rid of it. Yeah, healthy people don't consistently have high levels of free T3. So Sean, my pushback is against the goal of needing to have a high free T3. It's quite normal to have it mid-range, low normal. Those that consistently have high levels of free T3 have greater risks for metabolic syndrome, diabetes, obesity, other health complications. So you may be fine. That may not be a relevant issue. I'm going to drop a link up here, which will show up on the YouTube and Facebook. This is about how high should your free T3 levels be. And here it is right here. And this can give you some more insights about what I was just saying with a lot more depth and references, and also some guidelines by which you can figure out where would be your ideal free T3 levels. So that's going up right now. Boom. Couple more questions. Connie, quick one here. Is it true that a root canal can release toxins to the bloodstream? Sure. Yeah, you can have an infectious material that comes out. There's a lot of thoughts to talk about that being a specific cause for a lot of diseases, chronic root canals being causes of that. I don't have strong feelings either way about that, Connie. So yeah, just not my specialty, not my expertise. I don't want to guess about things that I'm not as confident or knowledgeable about. Let's see. So I've got a lot of good questions. So I'm just kind of picking and choosing through here. So I'm also thinking about trying to follow up on comments we've already started to talk about, taking a little bit deeper. So if one gets the iodine creatinine ratio test and the result is 0, ran twice to verify, does that mean they're one of the very small minority who's experiencing hypothyroidism due to iodine deficiency and not Hashimoto's. 0 ran twice. Well, not necessarily. So the creatinine ratio test is also not a test of nutritional status. It's a test of iodine clearance. That would mean that someone does not likely have recent high exposure to iodine or that they're not excreting high amounts of iodine. But to know one's nutritional status, it actually takes 10 tests to be within 80% accuracy and about 200 tests to be within 90% accuracy. So Sean, somebody who's not iodine deficient can P a 0 quite often. Now, Sean, what that means is you would be currently at a successful low iodine level. So the only time it's really useful to test iodine, and that's the best way to test it, is if someone has been going low iodine, but it doesn't seem to be helping them. And in that case, a test that shows high iodine would mean that they need more time or they need to be more thorough about identifying any hidden sources of iodine. If someone is on the low side of that, there's not really a nutritional too low unless you're testing yourself 10 times or a couple hundred times. And even then, you've got degrees of accuracy. And the thing is, Sean, like the thyroid reset diet, there's almost no foods that are devoid of iodine. There's just some that are a lot higher than others. So you never get none. It's actually biologically impossible to have none in your body. But it's quite common that iodine tests can bounce all over the place. So that's what that's showing. It doesn't mean that one is actually, it's not a diagnosis of iodine deficiency. Okay, let me grab another question. Let me get at least one more here. Kathy, I get this one for Kathy. I take 15 micrograms of Cytomel a day and take it sublingually, but it's not available now. I had T3 compounded since I will now be taking capsules and not sublingual, will be a difference in potency for me. Thanks. Kathy, if you're there still, I would love to hear more details if you were to share them. I don't encourage T3 by itself. You didn't say you're taking it all by itself, but I'm curious if you're taking it all by yourself. If you are, let me know and I'll talk about that. So the body clearly needs T4, T3, and T2. Now, we can't always make T3 in full quantities out of T4. We never make none, but we often don't make enough. And tons of people do better to get T3 along with their T4. And that could be natural thyroid or that could be T4 plus T3. It's fine. But the really superficial model about understanding thyroid hormones is that T4 is nothing more than a carrier for T3. That once you got T3, you never need the T4 to begin with. And there's some that say that quite vociferously. And it's just not true. There's a lot of things T4 does that T3 does not do. And that's true in the brain, in the liver, in the kidneys. So these hormones, there are many things in which they do overlap, in which T4 is really a means to T3. But there's a lot of things T4 does, T3 can't do. The other problem is that T4 and T3 separately work on the brain and on the TSH. So if one is only on T3, they've got to be greatly overdosed before they have a normal TSH, much more than they would otherwise need. The other problem is that if they do all that, then they're inhibiting their own output of T4. So people that just take T3, either they're taking far too little thyroid hormone, or if they're taking enough to control their TSH, they have no T4 present. And that's just not safe for the body. So yeah, some people do okay on just T4, many do better with T3, but there's just really no circumstances in which T3 only is a safe or a good option. So that wasn't what you were asking. Your friends will answer your questions, but your true friends will question your questions and go beyond that. So that was a true friend answer. Now, as far as sublingually versus capsules, well, the issue about absorbing thyroid hormones is rarely the problem that it's made out to be. There have been studies about people that have very severe bowel disease, and in almost all cases, they can still absorb thyroid hormones. So sublingual, and they have actually looked at sublingual absorption. Thyroid hormones, if they're taken sublingually, they're not really absorbing under your tongue. They're getting in your saliva and you're swallowing your saliva. It's still almost all oral absorption. So you wouldn't have a big difference from going from sublingual to oral, but you can get a big difference from going from pre-made to compounded, because there's just not the same quality control circumstances with compounded. Now, 15 micrograms of Cytomel, I'm guessing you were taking either a 5 and a 10 or 3 5s because 15 is not made. You take Tirosint too. Okay, Kathy, thank you for that. So my rant was not necessary for you, but maybe somebody else just on T3 was helpful for. And you're welcome for the true friend answer. And Kathy, yeah, I really wouldn't have pushed you to be on the sublingual, but I would worry about the compounded. And I love compounding for a lot of things. It's a great idea. And with it's different for synthetic thyroid than with natural thyroid. And here's why. So with synthetic thyroid, that shouldn't be a tongue twister. So Kathy, you're 15 micrograms of synthetic thyroid. If I could take those 15 micrograms and put them right there, none of us could see that without a microscope. That's far too small to see. But if you were to take 15 micrograms of T3 from natural thyroid, well, the only way you get that is with a tablet that contains ballpark of 1.5 grains, which is about 90 milligrams. And 90 milligrams is something you can actually see. So you can physically work with that. And you could take that and put that into containers. It's a physical mass that can be handled with a greater chance of accuracy. But 15 micrograms is microscopic. There's case reports each year about many events, some of which that are catastrophic, about compounded thyroid meds that were not made well. And of all of them, Kathy, T3 is the scariest. I know people who have nearly died from compounded T3. One woman that I did know, she never became a normal adult again. She completely lost brain function. She was prescribed a 7.5 microgram dose of compounded T3, not by another doctor, and she was given a 7.5 milligram dose. Now, those pills would have looked the same, and if you even shoot them up or taste them, they would have tasted the same. But a microgram and a milligram in your body, it's 1,000-fold difference. She had free T3 levels that were 10,000 nanograms per mil. It took her months to clear that out. There's no way to get that out. That's just riding through months of being catastrophically hyperthyroid. Now, that's extreme, and I don't at all want to say that that's a common occurrence because it's not. But if it can happen where it's off by that much, how often is it exact? And how often is it off by 10% or 40% or 30%? Well, we don't know because we don't look. There's no quality control process. There's no independent process that looks at things after they're made. Now, there are some pharmacies that do in-house testing, and that's good. And I do believe that can be effective for natural thyroid, because now we're talking about 90, 100, a few hundred milligrams. It's a big chunk of stuff. But with compounded, it's not a big chunk of stuff. So yes, I don't think that the sublingual 15 was really relevant. Now, 15 micrograms of T3 is a rather reasonable dose along with Tirosint, but you could probably do just as well back on Cytomel again and not need to do it sublingually. So that's just general thoughts about that. Okay, I'm seeing a lot of really, really good questions coming in. Someone is talking about compounded T3 as I was going on my rant. If you want to mention that further, I'm happy to elaborate more on my rant there. But she had an earlier question. Let's see. Working with a doctor, didn't address diet. So this is from Leaf A. It's an Instagram handle. Believes food is the best medicine. Told me Hashimoto's is not bad. TPO was low. Issues that I was thyroid resistant. Don't see any articles about that. Can you talk about it? Thyroid resistant. Yeah, Leaf A. Hey, great question. So thyroid resistant. Let me guess your scenario. So you're on the compounded T3. You're welcome to let me know if you're on other medication or just that. So thyroid resistant, what's usually happening is something that's not that, but it's being told that it's that. And what's usually happening is someone is taking a dose of thyroid that makes their TSH go low, and yet their T3 and T4 are also low. So tell me if that makes sense. Okay, so I take Synthroid 50 and Liothyronine 55. Liothyronine 55. All right, let's talk about this, you guys. So 50 and 55, and you're told you're thyroid resistant. So I'm going to guess that your TSH is well below range, but yet your T3 and T4, your doctor wants them to be on the high side, but they're not yet there. Tell me if my psychic hotline skills are working out or not. um, the TSH being really low, so you're on 50 micrograms of Synthroid. Let's put these into common terms. And the common terms that are used are called T4 equivalents. So T4 to T4 is just 1-to-1, so 50 is 50. Now, 55 micrograms of leothyronine, that's generic for Cytomel, that's a whopping dose. That's a really big dose. The comparison of T3 to T4, most consider 4 a pretty good factor. So 55 times 4 is 220. And let's add the 50 back in. So now 220 plus 50, so we've got 270 for the T4 equivalency. So what does that mean? Well, for someone to need a 270 T4 equivalency pill, Leaf, from your image, I'm guessing you're female, and women, it's different if they're menstruating or not, if they're on hormones or not. But for some ballpark numbers, your body will need about 8 or 9 tenths of a microgram of a T4 unit per pound of body weight. So let's make the math crazy easy. Most people aren't that small, but this is easy math. So if a woman was 100 pounds, she would need about 80 or 90 micrograms, okay? You're taking 270 micrograms. So if you were 300, 360 pounds, that might be a reasonable dose for you. Most people aren't 300 and 360 pounds, so very few need doses quite that high. But yeah, a dose of 50 T4 and 55 T3, that's about a 300 to a 360 pound person. And those are just totally goofy ratios. You never consider a 1-to-1 ratio of T4 to T3 like that. So I'm seeing your feedback. No, I'm not. I see a picture of you that's about that big. It doesn't look like you're 300 pounds. But yeah, so thyroid resistant usually just means that you're on too high of a dose and the doctor doesn't know why your TSH is low and your free hormones are low. And this kind of comes back to our comment earlier to where someone was asking about why is my free T3 low? If you're on an excessive dose of thyroid, that'll actually make your free hormones get low. And some doctors think that it's this thyroid resistant glitch. It can be thyroid resistant, but it's often not a glitch. It's often your body trying to protect itself. So when you take too much thyroid, you get really good at eliminating thyroid. Your mechanisms for eliminating thyroid through your urine primarily and through your stool, those things crank up into overdrive. And now you're just pouring it out like nobody's business. And doctors can see, wow, she's taking a big dose, but her T3 hasn't gone up. She must be resisting it. I better give her more. No, she's resisting it because she's getting too much. It's a really common scenario. Okay. One last comment. Let's see. So here's for Deborah. Hello, just found you a couple of weeks ago. Thank you for that. Glad to be found. Have been head deep in your work. Oh, hold on. Deborah's got a follow-up comment too. I'm going to go back and get both these. It's happening fast here. It's moving in real time. Got your book. Wasn't too much on hyperthyroidism. I'm pregnant 18 weeks. So hyperthyroidism during pregnancy. And now Deborah's giving some detailed labs. Yep, hyperthyroid. Prenatal has 150 of iodine. Should I take without? They want me on methimazole. Should I take them, then do less iodine? Yeah, Deborah. So super important thing. So hyperthyroidism of pregnancy, incredibly important for you and baby, for everybody involved. Now, what methimazole does is it slows the absorption of iodine into your thyroid. And in the subsequent 4 to 6 weeks, that will lower the amount of hormone coming out of your thyroid. Now, of course, it might take dosing adjustments that can happen, but that's how it works. It works by keeping iodine out of your thyroid. So your question is, should you avoid iodine? Well, let's think this through. From what you now know, now knowing that methimazole works by keeping iodine out of your thyroid, yes, you should lower your iodine intake. That'll make it work so much better for you. And it's a fair question because you hear about the need to take iodine while you're pregnant. That's being revisited, actually, and I've written a bit about that. No one should be iodine deficient, but the question is, what iodine level is healthiest for mom and baby? And does it require supplements to get to that level? And the emerging consensus is that in the modern world, many women are pushed above that level with iodine supplements. So even not knowing about the hyperthyroidism, there's not a strong case for taking iodine supplements during pregnancy. But to also need medication to slow iodine absorption, yes, that'll only work better with less iodine coming into your body. Now, another glitch is that prenatal with 150 micrograms of iodine, they've assayed these products. That 150 is probably 400. They don't have what they say they have. There was one analysis done of 60 prenatals, and they assayed to see how much iodine was in the pill. And they compared that to how much iodine the pills were labeled to have. None of them had what the labels said. They all had, well, I'm sorry, they didn't all have much more. A few had less, but most had much, much, much more. So yes, you're better off with that. Your complete thyroid safe for me or your hyperthyroidism pills. So Deborah, when you're pregnant, there's just really almost nothing that can be used besides a few items. So the daily bundle, totally fine, totally a good option. That's the thyroid specific multi. That's also calcium magnesium. That's a low iodine fish oil. Yes, Deborah, that's our daily bundle pack. And I'll get a list, I'll get a link to you for that. That's going to be right up here. This is the brand new line that I'm going to have connected to our normal cart in the real near term, but it's right here right now. And there's that. So that's a safe one without iodine. And then think through about the Thyroid Reset Diet book. With pregnancy and with hyperthyroidism, you're fine to do the thyroid reset as is with the green light foods. So yeah, good question. Okay, two quick follow-up ones. Leaf A, are you taking on patients or just the other doctors in your practice? So there's two answers to that. One answer is being a prescriber and managing care. And in that case, the doctors in my practice, they do that. They do take on people and they do manage their care, and they're awesome. We work with people in Arizona, California, Oregon, Washington, Idaho, Montana, 6 states. I'm pretty sure I got them right. That's kind of my order of confidence. Arizona or California, I'm totally certain. The others, I'm fairly certain those are the right 4. But yeah, we can help out with those states. Now, as far as personalized guidance, I can help out anyone, anywhere with that. I just saw a note, there's a few slots left before the summer break, and that's at thyroidopinion.com. You can jump onto Thyroid Opinion and just book a time with me. We can talk through all the stuff in really good detail. And what typically happens is it can involve what one would do with prescription medications, but I would give input that then your local doctor prescriber can help out with and just do. But I'm happy to give guidance and suggestions in just all aspects of that. And quick last one. You're such a nice doctor. Thank you for that, Sherry. Appreciate that. Given Japan's iodine intake, why don't they all have hashis? Krista. So Krista, hang out with me now for a second. My family is Scandinavian, right? So Christensen. I'm actually adopted. So my birth family was Irish, right? So Hashimoto's disease, Japan, Krista, Hashimoto's disease. Does that sound like Japanese? The Japanese don't all have hashis, but they have the highest rates of thyroid disease of anywhere in the world. Now, that includes autoimmune thyroid disease and it includes thyroid cancers. It's not a coincidence that a Japanese doctor was the first one to really dial in and understand what's happening with autoimmune thyroid disease. We named it after Dr. Hashimoto. We didn't name it after Dr. Larson or Dr. O'Malley if it was Irish. No, just the Japanese have the highest rates. Now, they've also had longer term exposure, and we can kind of get into the weeds about genetics, but if you're exposed to iodine for longer periods of time, your body gets more able to process it. So their rates would be a lot higher. When iodine intake changes in a population, that by itself causes a lot of thyroid disease. So Denmark, they went to a low level to a normal level, and they had a ton of thyroid disease show up. Japan's had a high intake for a long time. They've got a lot of thyroid disease. But if a nation that wasn't consuming that high amount suddenly went to that high of an amount, they would have much more thyroid disease. Almost everyone would probably have Hashis. Okay. How is this not known? Well, I guess my books aren't moving well enough. I'm doing my best to get this stuff out there, but That was it, though. So good to see you guys tonight. Lots of good questions. Do you treat patients, or is it just you giving guidance? Well, giving guidance, I'm not prescribing. I don't personally act as a prescriber. And I will give all the detailed guidance that can be useful, and I'll give notes that one's own prescriber can use, but I'm just not acting as a prescriber because I'm not currently practicing. If I were to do so, I would have to really control which state and also be available for follow-up. And my schedule changes. So I do second opinions, really, and I'm happy to give good detail with those. So good to see you guys. Have a wonderful evening. And I'm sorry, I cannot help myself. One last question. Blood work returned. Someone's giving their scores, highest ever. So it was returned to the prescription of armor 0.25. What's your opinion on armor? So this is from Cynthia. So Cynthia, you're talking. Oh, and I'm seeing a comment here replying to Krista. Second opinions are fantastic. Thank you so much for that, Krista. Appreciate the feedback. Cynthia. So Cynthia, where you are, that's called subclinical hypothyroidism. And those are blood levels that certainly can cause symptoms. They can cause you to not feel well. Cynthia, if you haven't, please grab the Thyroid Reset Diet. Dietarily, subclinical hypothyroidism can reverse upwards of 80% of the time. So Armor is a fine medication. The doctor is proposing a low dose. A low dose is the way to start out. And you can totally correct those blood levels with Armor. But here's the question I want you guys to ask. And I want you to think really, this is a nuanced thing, but we assume that these blood levels cause symptoms. We assume that if you change those blood levels with medications, that you can reverse those symptoms. But you can't. The data is just overwhelmingly clear that blood levels like yours, Cynthia, that they can get better, but that doesn't translate into better health for you. So if those blood levels were causing weight gain or fatigue or hair loss, or long-term they were causing a higher risk of heart disease, none of those things would improve by medicating with thyroid medication. And I'm not saying that bad about Armor. That's across the board for thyroid medication. This is the big thing that people don't get, is that in that situation, you can totally change those blood levels, but that wouldn't improve the situations. And that's an important difference. We want to assume that if the blood levels correlate with symptoms, that any way you change the blood level will help the symptoms. But the data shows us it's just not true. And that's why the policies have changed quite a bit as of late. So yeah, please know that you could improve those scores, but you wouldn't necessarily improve your health. Grab the Thyroid Reset Diet. You've got a really good chance of that reversing, and take charge of your health. There are many times where thyroid medications are needed and they are helpful, but subclinical disease is just not one of those. Ask your doctor for studies about showing clear benefits to any symptom or any health outcome with medication with subclinical hypothyroidism. And last one, Leaf, the website again, I think the one you're referring to was Thyroid Opinion. That's what I was talking about. That's where you can consult with me. So yeah, thyroidopinion.com. Cheers, you guys. Have a great evening. I'm going to make a healthy low iodine. Is it paella? I'm kind of embarrassed. I can't pronounce that right. It's the Spanish dish with a big variety of different foods in there. I'm going to make a low iodine version of that. I think it's paella. But I'll learn that, and I'll do better on that pronunciation next time. All right. Have a good evening. Bye-bye.